How do you treat a porn addiction that isn't official? If pornography addiction isn't officially recognized, how are we treating it? The short answer is clinicians are doing what they've always done, responding to distress, adapting what we know, and filling diagnostic gaps with practical tools. So let's start with the real-world presentations. Patients aren't quoting statistical manuals. They're saying, I can't stop. They're saying, it's affecting my relationship. They're saying, I hate myself for it. Many have tried to quit. They've installed blockers, deleted apps, made promises to themselves or others. Still, they come back. And that's what makes it clinically significant. So what do? Well, we focus on function over frequency. Is the behavior causing harm? Has the person lost control? Have they tried and failed to reduce or stop? These are red flags, regardless of diagnostic categories. The cornerstone of treatment is still psychotherapy, and right now, cognitive behavioral therapy, CBT, is the most studied, most effective option. CBT helps people map the patterns. It breaks the link between triggers and responses. It replaces automatic urges with deliberate choices. Studies show that CBT can reduce the frequency, intensity, and shame associated with porn use. It also improves self-regulation, a core weakness in many cases. Another option gaining traction is acceptance and commitment therapy, otherwise known as ACT. Instead of trying to eliminate urges, ACT helps people accept them without reacting. It shifts the goal from symptom reduction to values-based living. For patients caught in cycles of guilt and avoidance, that shift is absolutely critical. Then there is group therapy. It reduces isolation, provides accountability, and normalizes relapse. It's not about disclosure, it's about direction. Patients often say just hearing someone else speak their shame out loud changes everything. 12-step programs like Sex Addicts Anonymous do exist, though their religious tone and abstinence focus may not suit every client. Evidence is mixed, but some find them life-saving, especially when combined with individual therapy. Psychoeducation also plays a role, teaching patients about craving cycles, brain changes, and how behavior becomes conditioned gives them a framework to understand their struggle. It helps reframe I'm broken into this is treatable. But sometimes therapy alone isn't enough. That's where pharmacological support comes in. Let's start with SSRIs. These are commonly used when obsessive or compulsive features dominate. Fluoxetine, sertraline, and paroxetine have been used in small trials or case reports. Patients often report reduced sexual urges and lower levels of anxiety. But it's not a silver bullet. SSRIs can also cause sexual side effects, emotional numbing, or in rare cases, substitution with another compulsion. More recently, opioid antagonists like naltrexone and nalmefene have entered the picture. One case study followed a man treated with nalmefene 18 milligrams daily for over a year. His symptoms dropped significantly. When he stopped the drug, his cravings returned almost immediately. Restarting nalmefene brought those symptoms back under control, and he remained symptom-free for a further 2 years after treatment. Naltrexone, more commonly used especially for alcohol use disorder, shows a similar promise, especially when porn addiction is comorbid with substance use, gambling, or compulsive eating. These drugs work by blunting the brain's reward response. They don't kill desire, but they interrupt the loop. It's worth noting that these are off-label uses. There are no TGA or FDA-approved medications for porn addiction, but these drugs are accessible, relatively safe, and based on a plausible neurobiological model. For people who've tried everything else, they are worth considering. Now let's zoom out. Porn use is rarely the only problem. It's often tangled up with depression, anxiety, ADHD, trauma, relationship issues, or chronic loneliness. If we treat the symptom but ignore the system, we miss the point. That's why a good treatment plan includes a full mental health assessment, careful screening for trauma and compulsive patterns, a focus on function, not abstinence, and a therapist who can work without moral judgment. Another critical factor is early exposure. Many patients started watching porn before puberty. Some were exposed to violent or extreme content early, setting up distorted expectations or emotional desensitization. That conditioning is not undone quickly. It takes time and trust. Patients often ask, do I have to quit porn completely? And the answer isn't one size fits all. For some, abstinence makes sense. For others, it's about reducing use to a level that no longer impairs their life. Either way, the goal is the same, which is to regain control, return to function, and reduce the shame. Because, let's be clear, this isn't about porn. It's about compulsion, avoidance, loss of choice, loss of control. The field is still evolving. There are gaps in the evidence, but not in the need. And just because something isn't officially recognized doesn't mean it isn't real. Coming up in episode 3, we look at who's actually seeking help, what recovery looks like in the real world, and what helps patients stay on track. That's all for today, folks. My name is Dr. Ferghal Armstrong, and this has been Cracking Addiction.